Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I am a cardiologist, and today we are going to talk about mitral stenosis. Mitral stenosis is one of the most interesting topics. When I was in medical school back in India in the 70s, this was one of the most important topics that we had to know in order to pass the medical examination and get into residency program. However, the mitral stenosis has been still prevalent in the developing countries. Mitral stenosis is very infrequently seen in United States or other developed countries. But still, we do get certain questions on mitral stenosis, so it's important to learn something about mitral stenosis. And mitral stenosis is one of the fascinating topics, especially for echocardiographers to use all the modalities they have in order to find out the valve area and also look at the structure of the valve, the leaflets, the commissures, and many other things related to mitral stenosis. The objectives of this presentation include definition of mitral stenosis, epidemiology, etiology, pathophysiology, history and physical examination, diagnostic tests, and of course management and prognosis. So let us continue. Mitral stenosis is a condition where there is narrowing of the mitral leaflets, reducing the mitral orifice, leading to a gradient between the left atrium and the left ventricle. In most instances, mitral stenosis is predominantly caused by rheumatic fever, which leads to commissural fusion, and occasionally we can also see degenerative mitral stenosis with severe mitral annular calcification, especially in the elderly hypertensive patients with atherosclerotic heart disease and aortic stenosis. Congenital mitral stenosis is an abnormality of subvalvular apparatus of the mitral valve. I have not seen one case, so it is extremely uncommon. Other conditions that may be associated with mitral stenosis include systemic lupus, infiltrative myocardial diseases, carcinoid heart disease, and sometimes drug-induced valvular heart disease. Let's look at rheumatic mitral stenosis, which is the most common form of mitral stenosis. It accounts for more than 99% of the mitral valves that are surgically treated. In rheumatic mitral stenosis, there is scarring and fusion of the valve apparatus. Mitral regurgitation is seen in approximately 40% of all patients with mitral stenosis. 2/3 of the patients with mitral stenosis happen to be females. Here are some pathological features of rheumatic mitral valve disease, which include commissural fusions, fusion of the commissures. Then there is a shortening of the chordae tendineae along with the superimposed calcification, and calcification becomes more prominent as the disease progresses in the third and fourth decades. There's also degenerative mitral stenosis. There is annular calcification which comes with age, and relatively there is a thickening of and calcification of the leaflets themselves at the base. And all of these lead to the adherence and restriction of the mitral apparatus. In some cases, the apparatus is so calcified and fixed, there is hardly very little movement during each cardiac cycle. Narrowing of the mitral orifice between the left atrium and the left ventricle leads to a number of hemodynamic changes. Because of the narrowing, there is elevation of the left atrial pressure. There is reduced output going into the left ventricle, which results in reduced cardiac output. This elevated pressure is transmitted through the pulmonary veins into the pulmonary circuit and then into the right heart, which leads to right ventricular pressure overload and pulmonary hypertension. And as I already mentioned, the reduced left ventricular ejection fraction can lead to reduced cardiac output symptoms. Along with this, there is also associated tachycardia in response to compensate for the reduced cardiac output. Finally, as the mitral stenosis progresses, there is development of pulmonary hypertension. Clinical diagnosis of rheumatic fever. This is something I saw when I was in medical school. I have not seen a case of a rheumatic fever diagnosed at bedside since I have been in the United States for more than 40 years. Anyway, the diagnosis of acute rheumatic fever is based on two major Jones criteria, or one major criteria and two minor criteria. This could be a question they may ask you even though you may never see mitral stenosis or rheumatic fever in your lifetime. Anyway, the major Jones criteria for rheumatic fever include myocarditis, erythema marginatum, chorea, and subcutaneous nodules. The minor criteria include fever, PR prolongation, elevated sedimentation rate, and history of rheumatic fever. And in these patients with rheumatic fever, we may be able to hear a soft diastolic murmur, which is known as the Carey-Coombs murmur. So you want to remember Carey-Coombs murmur because they can ask you as a question as in what condition do you hear Carey-Coombs murmur? That is in patients with acute rheumatic fever. The symptoms of patients with rheumatic fever include many of these. Usually the rheumatic fever happens in the second decade or so, and there is generally a latent period of 1 to 2 decades before these patients develop symptoms, and after that there is progression of this disease over the next decade, which can eventually become a crippling condition. The majority of the symptoms related to mitral stenosis include shortness of breath. Shortness of breath is because of increased pulmonary congestion and pulmonary hypertension. So this is one of the predominant symptoms of patients with mitral stenosis. These patients can also develop orthopnea and PND because of the back pressure built up into the pulmonary veins and into the pulmonary circulation that can produce orthopnea and paroxysmal nocturnal dyspnea. Chest pain can also be felt by these patients because of reduced cardiac output. They can also have hemoptysis because of pulmonary congestion, and because of reduced forward cardiac output, these patients may experience fatigue. In addition, they can also develop palpitations because of atrial ectopic beats, which eventually can lead to atrial flutter or fibrillation. Again, we are going to see the predominant symptoms of right heart failure with hepatomegaly and peripheral edema. Clinical examination. Palpation may reveal a small volume pulse because of the reduced cardiac output. You may feel a tapping apex, which represents the palpable S1. You may also be able to feel a palpable opening snap if the leaflets are pliable. In addition, because of right ventricular hypertrophy, we may feel right ventricular lift. We may also feel a palpable S2. Auscultation of the chest reveals a loud S1, as loud as S2 in the aortic area. The aortic second sound to the opening snap of the mitral stenosis interval is inversely proportional to the severity. One of the hallmarks of mitral stenosis is the diastolic rumble. We have the opening snap, and that will be followed by a low-pitched diastolic rumble. And in severe mitral stenosis with low flow, S1, the opening snap and the rumble may be almost inaudible. We may see this in patients with critical stenosis, where the flow across the mitral valve is considerably decreased. Here is a phonocardiographic representation of the heart sounds and the murmurs seen in patients with mitral stenosis. Here we have a loud S1. After that we have S2, and following S2 we have an opening snap, which represents the opening of the snapping of the mitral valves as they open. This is followed by the mid-diastolic low-pitched rumble. One of the characteristics of this rumble is it is heard best at the apex, with the patient lying on the left side using the bell. Then we have a pre-systolic murmur, After that, we have this first heart sound coming again. In order to contrast the murmurs and clicks we hear in patients with mitral stenosis, here is a representation of some of the other murmurs that we can hear during a cardiac cycle. As I said, there are only a few situations that cause diastolic murmurs, namely aortic regurgitation or pulmonic regurgitation, and mitral stenosis, or very, very rarely tricuspid stenosis. However, there are a number of conditions that can cause systolic murmurs depending upon what type of lesion we are dealing with. Basically, we have the ejection systolic murmur, which is a high-pitched murmur heard in patients with aortic stenosis and pulmonic stenosis. Then we have a hollow systolic murmur, which is lasting throughout the entire systolic phase. We hear that type of murmur in patients with mitral or tricuspid regurgitation. Then in patients with the mitral valve prolapse, we have a click followed by a mid-systolic murmur, which is not as high frequency as that we hear in patients with aortic stenosis. Again, we may hear a holosystolic murmur in patients with ventricular septal defect. It is not mentioned here. And sometimes we hear a both systolic and diastolic or the continuous murmur in patients with patent ductus arteriosus. Now let's look at the electrocardiogram. Electrocardiogram may suggest some evidence of left atrial enlargement with a sort of a biphasic P wave. We see a peak P wave here, but it's usually biphasic because of the left atrial enlargement and right ventricular hypertrophy. These are some of the findings on a resting electrocardiogram, but nonetheless, mitral valve can also cause havoc on cardiac rhythms, such as creating premature atrial complexes, and also mitral stenosis can lead to atrial fibrillation with rapid ventricular response or occasionally atrial flutter. These arrhythmias can make the mitral stenosis symptoms worse. Here is a chest X-ray. Generally, we may not see very significant findings in a patient with mitral stenosis in the PA chest film, except for the straightening of the left border here, which is suggestive of a pulmonary enlargement secondary to pulmonary hypertension resulting from mitral stenosis back pressure. This double shadow that we see here is supposed to represent the left atrial enlargement, which is behind the right atrium. Again, we may see some changes in the vascular bed due to increased pulmonary vascular markings. The left ventricle may appear to be normal because the left ventricle is generally small in patients with mitral stenosis. However, if you look at the lateral chest film, we can see a clear enlargement of the left atrium, and if you do a barium swallow, you can see an indentation on the esophagus by the enlarged left atrium. Echocardiography is the gold standard today in terms of identifying various abnormalities related to mitral stenosis, along with precisely assessing the degree of mitral stenosis, the various commissures and the various structures that are involved in mitral stenosis, and to help us in identifying which patients are suitable for mitral valvuloplasty or which patients need to go for mitral valve repair or replacement. There's both transthoracic echocardiography and transesophageal echocardiography. They are both complementary because we can look at the structure of the heart resulting from mitral stenosis. The transesophageal echocardiography gives a much higher accuracy than two-dimensional transthoracic echocardiography. It also provides detailed information of the commissural fusion and the subvalvular apparatus, namely the chordae tendineae, and any fusion between the chordae, etc. Mitral valve area measurement can be accurately assessed in calcified and irregular valves. Again, we can assess the results of patients who have undergone mitral valvotomy or valvuloplasty or valve replacement. So, echocardiography, both transthoracic and transesophageal, are very essential in diagnosing patients with mitral stenosis, in determining what type of procedure they would need, and in following up with their progress or regress after an intervention. Other features that we find in patients with mitral stenosis include enlargement of the left atrium, pulmonary hypertension, mitral regurgitation, coexisting aortic or tricuspid valve problems, along with small left ventricle and normal left ventricular systolic function. Here is the good old days when back in the 80s when I was doing fellowship in cardiology. This was the only gold standard that was available for echocardiography in terms of diagnosing mitral stenosis. Some of you may not even see this in today's modern echocardiography, but nonetheless here is a normal looking mitral valve showing the E and A deflections related to the early filling and atrial kick, and in patients with mitral stenosis the E to F slope is almost non-existent, along with the thickening of the leaflets and the anterior motion of the posterior leaflets. All these simply suggest a very stiff stenotic valve which is non-flexible or non-pliable, and this is suggestive of severe mitral stenosis. Along with that, we can see thickening of the leaflets here, along with doming of the mitral leaflets during atrial systole. And here's an example of doming of the mitral leaflets during left atrial systole, and there's also severe restriction of the movement of the anterior leaflet. So there are a lot of things we can identify on two-dimensional echocardiography. It will also help us to identify the structure of the leaflets, the movement of the leaflets, shortening of the chordae tendineae, and all of these things are very vital in determining what type of management is most suitable for a given particular patient. The additional findings that we may see are calcification, left atrial enlargement, and of course right ventricular enlargement due to pulmonary hypertension, and maybe right atrial enlargement also. And sometimes we could see paradoxical septal motion that we see in patients with the pulmonary hypertension. If you do the cross section of the left ventricle and the right ventricle, you may see a D-shaped septum, which is characteristic of pulmonary hypertension. And here's an example of a calcification of a rheumatic mitral leaflet. Echocardiography can also be used in the short axis to actually look at the mitral orifice along with the leaflets. As you can see, there is thickening of the leaflets, there is narrowing of the mitral orifice. By using a planimeter around the opening, we will be able to calculate the mitral valve area. This is especially useful in transesophageal echocardiography, where we can get a much better delineation of the edges of the leaflets, so we can accurately measure the mitral valve area. Complete fusion may indicate severe mitral stenosis, and if the orifice size is less than 1 centimeter square, that is suggestive of critical mitral stenosis. The normal mitral orifice ranges from 4 to 6 centimeters per square, so you have to get the mitral valve area reduced by more than 75% before the patients become symptomatic. There are various hemodynamic and color Doppler based calculations that can be used to calculate the mitral valve area besides using the planimeter. There are two levels. Level 1 is recommended for basic evaluation. Level 2 is a higher level where they use continuity equation and PISA, which is proximal isovelocity surface area method, and stress echocardiography. But for most practical purposes, we should be able to get a fairly accurate mitral valve area using pressure gradient, which we're going to look at in a minute, along with mitral valve planimetry, which I already talked about, and also using pressure half time. And surprisingly, all these calculations are done by the modern echocardiography machines. So basically, we just need to get these numbers and then calculate the mitral valve area. Here is a Doppler pressure half time area. As we can see, in a patients with mitral stenosis, there is decreased E to F slope. Because of the stenosis, it takes longer time for the pressure to drop as compared to patients with normal mitral valve. Time for the peak transmittal pressure to drop by half is taken as a measurement, and by using that we can calculate the mitral valve area by using this formula 220 divided by pressure half time, as it is called. Here's an example, just again looking at pressure half time. Draw a line at which point as the velocity falls to 1 over 1.414 from the peak, and from there you calculate the time, and that time is used to calculate the mitral valve area. Surprisingly, the computer does, like in this case, we're using a continuous wave Doppler to measure the pressure, and here it already gives us the mitral valve mean gradient is 15 millimeters of mercury. The maximum is 15 and the mean gradient is 10 millimeters of mercury with a mitral valve velocity time index of 70 centimeters. So all these things help us to calculate the degree of mitral stenosis. This is just an expanded version, a different example. Here we have a mean gradient of 13 and a maximum gradient of 24 millimeters of mercury with a mitral valve velocity time index of 85, which is much more prolonged than the previous one. In order to measure the pressure gradient, we need to use a continuous wave Doppler. The gradient is measured best in the apical window. Color Doppler can be used to identify the eccentric diastolic mitral jets. Doppler beam is guided by the highest flow velocity zone identified by the color Doppler. Mean gradient is a relevant hemodynamic finding. Because of patients with atrial fibrillation may have varying time intervals, we have to average at least 6 to 10 beats to get an average gradient across the mitral valve. And again, we talked about doing a plenimeter. As you can see, these valves leaflets are extremely thickened. The orifice is extremely narrow. However, by using the plenimeter, we can calculate the mitral valve area in these patients. It's a three-dimensional echocardiography, which is giving you a much better visual image of how things might look during surgical operation. Here are the leaflets, which are extremely thickened, along with a very significantly narrowed mitral valve orifice. This is one more example of showing how to measure the mitral valve area and showing varying degrees of mitral stenosis. Two-dimensional echocardiography is very useful in identifying the mitral valve area, and we already talked about using plenimeter, Doppler, pressure gradient, pressure half time, and a whole host of other advanced techniques. Here is an example of a proximal isovelocity surface area, which uses a complicated formula by looking at the jet that is coming through and the disbursement of the blood, and based on that we can calculate the mitral valve area. The normal mitral valve area is between 4 and 6 centimeters per square. When the mitral gradient is less than 5 millimeters of mercury, the valve area is greater than 1.5 centimeters with a pulmonary artery pressure of less than 30 millimeters of mercury. If the mitral stenosis is moderate, then we may see a gradient between 5 and 10 millimeters of mercury with a PA pressure between 30 and 50 millimeters of mercury, and the valve area between 1.0 and 1.5 centimeters square. Severe mitral stenosis is where we see a mitral valve gradient of greater than 10 with a PA systolic pressure of greater than 50 and a mitral valve area of less than 1. In some institutions, they may be still doing cardiac catheterization to calculate the mitral valve gradient, because that's how I did mitral valve calculation during my cardiology fellowship back in the 80s. We measured the left atrial pressure, which was the Swan-Ganz pressure, which was superimposed on the left ventricular pressure to get the mitral valve gradient. And by using this mitral valve gradient, we use the mitral valve area formula, which is a mitral valve flow divided by 38, which is a constant, multiplied by the mean mitral valve gradient. But nowadays we really don't need to, because the 2D echocardiography and transesophageal echocardiography are so powerful in identifying so many things about the cardiac structure, function, valve stenosis, and regurgitation. We rarely do we need to resort to this one. Again, this is another continuity equation which says that the amount of blood coming through the mitral valve is equal to the amount of blood going through the left ventricular outflow tract. So by knowing the left ventricular area of the aortic valve, we may be able to find out the area of the mitral valve based on this formula. The complications of mitral stenosis include atrial dysrhythmias, most notably atrial fibrillation. With the onset of atrial fibrillation, patients' conditions can deteriorate very rapidly, because atrial fibrillation can reduce the cardiac output by 20 to 30% in a patient who already has low left ventricular output. Systemic embolization can happen in 10 to 25% of the patients during their lifetime with mitral stenosis, and the risk of embolization is related to age, the presence of atrial fibrillation, the left atrial size, and previous embolic events. These patients also manifest with right heart failure. They may also be subject to pulmonary infarction because of severe right heart failure. Hemoptysis secondary to ruptured bronchial veins. Endocarditis is another complication that we may see in patients with rheumatic heart disease. And of course, pulmonary infections are pretty common and frequent in patients with mitral stenosis. The natural history of mitral stenosis is interesting, because initially from the onset of rheumatic fever, it takes a long time before these patients ever develop symptoms. It is usually slow and stable in the first 1 to 2 decades. Then there is progressive acceleration in the later years, between 20 to 40 years of latency from rheumatic fever to symptom onset. And after the symptom onset, the condition takes a fairly rapid course with disabling symptoms, with worsening of the stenosis, and along with complications such as atrial fibrillation and embolic events. The medical treatment for mitral stenosis, of course, include reducing the pulmonary congestion by using diuretics, and we can also use the digitalis and beta blockers to reduce the heart rate in patients with atrial fibrillation. Calcium channel blockers can also be used to control the rate in atrial fibrillation. Anticoagulation is an important element of treating patients with the atrial fibrillation. Endocarditis prophylaxis is an important thing to keep in mind. Interventions, as far as interventions are concerned, we have either percutaneous intervention or surgical intervention. Percutaneous interventions can be done through the groin, going through the right heart, and the catheter is passed through the right atrium into the left atrium, and from there a balloon is passed across the mitral orifice, and the balloon is dilated. As you can see, the dumbbell shaped balloon, and once it opens up some of the commissures and the chordae, you can see there is widening of the mitral orifice, which can give a dramatic improvement in symptoms from this procedure. Again, a very careful screening has to be done before these patients are considered for mitral valvotomy. Their leaflets have to be pliable, and there is no significant mitral regurgitation in these patients to start with. Surgical approach to mitral stenosis include mitral commissurotomy or mitral valve replacement with mechanical or bioprosthetic valves. Again, when we consider mitral commissurotomy, 2-dimensional and 3-dimensional echocardiography are essential to understand the anatomy, structure of the mitral valve apparatus itself. We had to look into the mitral leaflets, the commissures, the chordae, any evidence of heavy calcification, and all of these things have to be taken into consideration before we can consider mitral valvotomy or mitral valve replacement. Patients with mitral valve replacement have a pretty good prognosis, but they need to be continued on all the medical treatment they were on before the surgical procedure. Now, here are the American College of Cardiology, American Heart Association, Class 1 surgical intervention indications. Which patient should undergo surgical intervention? Basically, there are three different groups. Let's look at each one of them. You can forget about everything that's in blue because I have simplified things. If you have a patient with moderate to severe mitral stenosis, if they have class 3 or 4 symptoms, and if they are not amenable for a valvuloplasty because of heavy calcification, fibrosis, shortening of the chordae, and things like that, then we may want to consider surgical intervention. Similarly, patients with class 3 to 4 symptoms whose mitral valve area is less than 1.5 centimeters square, who also have evidence of left atrial thrombus despite anticoagulation, should be considered for surgical intervention, because you don't want to put a balloon in a patient with a left atrial thrombus and dislodge the embolus, which can be much more devastating than the underlying mitral stenosis itself. The third group of patients are again those with the class 3 to 4 symptoms who have a mitral valve area of less than 1.5 centimeters, whose leaflets are not suitable for valvuloplasty. So, ladies and gentlemen, echocardiography is not only useful in diagnosing and deciding what kind of treatment we need. Echocardiography also plays an integral part of the lifelong story of a patient with the mitral stenosis. We should get serial echocardiography every 3 to 5 years, in mild every 1 to 2 years in patients with moderate, and yearly echocardiography in patients with severe mitral stenosis to study their mitral valve structure, their function, and then determine. We have to understand that the medical treatment of mitral stenosis is purely symptomatic, because mitral stenosis, like aortic stenosis, is a mechanical problem which needs either percutaneous intervention or surgical intervention to relieve the stenosis. Nonetheless, even after mitral valvotomy or surgical intervention, these patients need to be continued on beta blockers, calcium channel blockers, digoxin for control of heart rate, and diuretics for any volume overload. So, ladies and gentlemen, this is a brief overview of mitral stenosis, its etiology, its pathology, clinical findings, diagnostic tests, and management. Thank you so much for watching, and please do subscribe to our YouTube channel, and we will see you next time. Please remember, we have more than 100 videos on cardiology topics on our YouTube site, and we would like you to please visit these other lectures and make use of them. Thank you so much. We will see you next time.